Welcome. It's Friday. It's October 29th, 2021. And yes, I am coming to you live at 4 p.m. or a little bit after. So, anyway, as you know, I am a board certified gynecologist specialized in anti aging, hormone balancing, and wellness. I also have a master's in public health. And so, obviously, the public health and safety of our women, children, and all of the people in the world is very near and dear to my heart. So, we're kind of deviating off a little bit more. We've been doing the COVID live talks, and I was actually absent the last 2 weeks, which is the first time since COVID started. But I was actually teaching a course 2 weeks ago, and then I was actually at a conference the following week. So, sorry about that. But we're back, we're good, and we actually have a guest speaker, and we're going to delve off a little bit off of COVID. We'll brush a little bit on it, but mainly this is Breast Cancer Awareness Month. We're coming to the end of it. And, we talked about it a little bit a couple of weeks ago. And I have all my breast cancer awareness stuff that I was showing you a few minutes ago when you weren't able to see it. And so it's very important that we are aware of breast cancer and what we can do as women to take care of ourselves, to decrease our risk of getting breast cancer, as well as if we're breast cancer survivors, what to do. And then also, if you are one of our males watching, you have someone of the female persuasion, I'm sure it's whether it's mother, sister, lover, wife, daughter that has breast, and so learning more about that is important to you as well. And yes, men do get breast cancer, extremely rare compared to our female counterparts, but it is possible. So, all right, we have a guest speaker with us today, yay, which is Dr. Danielle Henry. She is a board-certified general surgeon and a fellowship-trained breast surgical oncologist. She's with the Breast Care Center at Orlando Health the Cancer Institute, which is here in Orlando, Florida. As you guys know, my office is located in Central Florida, in Claremont, about 20 minutes west of Orlando. And she's very dedicated to providing comprehensive care to women with all types of disease of the breast. Her passion is empowering women through education about breast cancer and about breast health. And we are very excited to have her. So without further ado, I will introduce you to Dr. Henry. Let's add her in. Hello, welcome.
Hi.
And
Good evening, everyone.
and
How's
a little bit
everyone
of
doing today?
housekeeping. If you guys cannot hear, please send up a smoke signal. If it starts to sound warbled, anything like that, please let us know. You know that I am technologically challenged at times, so you're not offending me if you can't hear or anything like that. So I'm sorry, I didn't mean to cut you off. I just want to make sure they know, because I like for them to keep us abreast if there's any, no pun intended, if there's anything that we need to be addressing on that end. So why don't you give us a little bit of, I gave you a little intro, but if you'd like to give a little bit more, feel free. You have the stage.
Absolutely. Well, thank you so much for having me on. October is definitely a busy month as we talk about breast cancer awareness, but in my line of work, breast cancer awareness is every month. We want to make sure that women have the information that they need to take good care of themselves and their health, and their breast health is definitely one of those things. I work at the Orlando Health Cancer Institute, and we have several locations across Central Florida, and we just strive to bring patients the best care for their health overall and their breast health and breast cancer specifically. So that's me in a nutshell.
Oh, great. So we
And
talked a little bit about breast cancer, like I said, a couple of weeks ago, kind of went over general statistics and stuff like that. And one of as you were mentioning, and I think that a lot of people don't know that the statistics do lag by a couple of years, but that
mhm,
normally it's thought that the for most women that it's about a 1 in 8 chance of getting breast cancer at some point in their lifetime, and
yep,
that we're here today. We're going to try to talk about some of the things that people hear, and try to dispel some of the myths that people hear about it versus the truths, etc. And so, one of the things that I always have heard a lot of people of color say is that, well, that's, I'm less likely to get breast cancer. It's more, black women or Hispanic women or Asian women don't get breast cancer as much as their white counterparts. And so one of the things that I wanted you to kind of discuss is that, um, clarify that for them.
Absolutely. So a lot to unpack there. So
Yes.
let's start off with like how common is breast cancer? So like you said, about 1 in 8 women will be diagnosed with breast cancer in their lifetime. What most people don't realize is that our risk for breast cancer goes up the older we get. So that 1 in 8 chance, or about 12% chance of developing breast cancer in your lifetime, actually is in women in their like 70s and 80s. So as we get older, our risk goes up. So some women think, well, I'm too old to get breast cancer. Well, the truth is, the older we get, the higher the risk goes.
Yes.
Now, as far as looking at how is breast cancer distributed amongst the different ethnic populations, so we do know that breast cancer is more common in white females, so non-Hispanic white females. However, the way that it affects different ethnic groups is different. So, unfortunately, when we look at who is more likely to succumb to breast cancer, so who's most likely to die from breast cancer or breast cancer diagnosis, it unfortunately is in non-Hispanic Black women. So, and women of color. Um, One of the reasons for that is that we see that it happens more in women less than age 40. So, as you know, most women are supposed to start screening for their mammograms at age 40. Well, if you are in a group where it is a little bit more common before the age of screening, then that may lend itself to you being diagnosed at maybe a later stage of disease or with a more aggressive type of disease. And so that's one of the reasons why we see a difference there. But the good news is that overall, the incidence of breast cancer is starting to level out. And the amount of deaths that we see from breast cancer is actually decreasing. How is that the case? Well, because we have better imaging and better treatments for breast cancer, which is making it definitely a treatable and survivable disease.
Right. Great. And I think that that's
Yeah.
really important. I try to stress to my clients that we actually recommend a baseline mammogram at 35. And what I tell them
Hmm.
is, I'm not here to control your insurance. So even though my recommendation and your insurance company's recommendation could be two different things, but that your health is the most important
Right.
thing. And that, so we recommend usually one at 35 as a baseline. And then at 30, we do like kind of a 37, 38, a middle child, and then we at 40 start recommending every single year. And yes, we get that all the time. Well, I've been doing them now, I'm 60 or whatever, I can stop that. Right? No, it's actually more of
Yeah.
the incidence of cervical cancer actually starts to go down the older you get, assuming that you're with the same partner,
Okay.
and that you've had normal pap smears. And that's why you hear about the pap smear things changing as far as the recommendations. I think that one of the things that confuses women is that, every once in a while we go back to, okay, now it's all right not to get your mammogram every year. Okay, now you can do it every 2 years. And then after a couple of years, they're like, oh, crap, the numbers are going back up again. And then they flip it back. And so I
Yeah.
think that that's part of what confuses people, is the wishy-washiness of the recommendations at times. So,
Absolutely. There's definitely a lot of societies that have different opinions, but the American Cancer Society, the American College of Surgeons, the radiology societies, all of them agree that that women should have the option to start their screening mammograms at age 40, and it should be done every year. And I love that you recommend women get a baseline at 35. I think that's great, and that's definitely going to account for some women who may develop the disease earlier. So, another myth that we kind of hear is I'm too young to get breast cancer. And I think we've seen a lot of it in the news this month, especially in Florida, um, that young women are developing breast cancer. So it's not as common, but it can happen. And a lot of changes to how women move through society these days. So, women are delaying childbirth and having a child after over a short period of time. Um, just a lot of changed over time may be contributing to that, that we're seeing more and more.
Right. I think there might have been a little bit of a delay there. I was switching out my volume because I was hearing a lot of interference. So they may not have heard your last
Okay.
couple of sentences. Can you hear me?
Okay.
You can hear me.
Yes.
Okay. Yeah. So maybe just repeat just what you were talking about from Florida about,
Yeah, so this month there's been a lot in the news about younger women being diagnosed with breast cancer, especially with the governor of the state's wife being recently diagnosed. And so, one of the things I was mentioning is that some people may think that they're too young for breast cancer, and we are seeing a lot more breast cancer in younger women. The jury is still out as far as what exactly is causing that, but we do know that there have been some changes in pattern of reproduction, and this is definitely up your alley. We see
mm-hmm.
that women are delaying childbirth, so they're having children later in life. And we do know that there's a slight increase in the risk for breast cancer in women who have children after the age of 30.
Right, 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 definitely. So it's not a
Yeah.
reason to run out and have a baby, please.
No,
But
no.
I think because you don't get to give those back. But yes, there are a lot of women do delay. I mean, I certainly didn't have my child until I was 37. So I
Right.
think that uh, there that is definitely more common, and we are seeing that. And so, like I said, when there are recommendations on things that you can do to decrease your risk, you do the best you can with what you've got. And so,
Absolutely.
there's so many other things that are really important to protect yourself. So if you haven't had a baby before 30, that certainly does not mean that you are doomed to get breast cancer by any way, shape, or form.
No.
These are just things that are just, when we do statistics and we look at what seems to be a potential factor to cause something, that's one of the things. Also, breastfeeding is actually protective. And so, but that doesn't mean, yeah, breastfeeding is good for the baby too. And so there's a lot of benefits to breastfeeding,
Right.
but a lot of people don't know that that is actually protective towards decreasing your risk for breast cancer. So if you were someone that
Wow.
is considering breastfeeding, that would be a good thing. And
Yeah, absolutely. I just think that one is that, like you said, there's so many things that do contribute to the development of breast cancer. We just can't pin it on one thing. And I honestly believe that cancer is not fair. So for even the person that fits the perfect picture of someone who should never develop breast cancer, it can happen and we see that. And so really we just have to focus on the things that we can control, because a lot of those things that are on the list that increases a risk for breast cancer, we don't get to control. Like the two biggest risk factors are age and female gender. We don't get to decide what gender we're born, and everybody wants to live a long and healthy life. And so those are two things that I think, are out of our control. And, we just strive for longevity and health.
And I think that the key thing is that people need to realize is that we're all, it's interesting, and obviously you see, when you seeing them, they're obviously concerned because there's something going on with their breast usually. But
Yeah.
from my point where I'm doing a preventative thing where I'm seeing patients on a regular basis and they may or may not have issues with their breast. Um, I will tell you that when I'm diagnosing someone or telling someone that they have breast cancer compared to, say, uh, any other cancer, there's something about women and their breast. It just is, not to say that we're not scared of any other cancer. Nobody wants to hear the word cancer. I always tell my clients, nobody wants to hear the word cancer out of my mouth. I don't want to hear it in regards to myself. So it is extremely scary. But breast, there's just this whole nother level of, for some reason, I guess because we're female and it's something unique. I mean, not to say that men don't have breasts, but they don't have breasts the way we have breasts. And so it's
Right.
just something about it that is just even more. overwhelming to women, I guess. I don't know. I can't, it's just very interesting how we interpret that news versus say other news. And it's not, and so what I like to tell people is that, realize that 1 in 2 women is still the number one killer of women is heart attack and stroke. And so,
Yeah.
you may, and this is what I tell my patients too, is I say, look, if you get breast cancer, that means you haven't been knocked off by one of the other two. As you get older, you're gonna die of something. You're gonna get stuff. Unfortunately, there's that rare
Yeah.
person that is just wonderful, that never takes a pill a day in their life, never has high blood pressure, never has diabetes, and we love those people. We hate them at the same time too. But and then some of those people are just people that just don't go to the doctors and just don't want to know what they've got, and they may have things out there. But
Fair.
we know that 1 in 2, that means you, me, both of us are going to probably die of a heart attack or a stroke. So put things in perspective. Even though 1 in 8 women will get breast cancer, that's not how many women die of breast cancer. So even though, yes, it's very serious, and I'm not saying don't take it seriously, it's extremely serious, and we do want you. That's what we're on here for, is to make you aware and to make you
Yeah.
take your breast health seriously. But it doesn't mean that's the only thing. And I just like you to put things in perspective, that it's not the only big thing out there that you have to worry about, because I think a lot of people hone in on cancer, and I think it's that helplessness feeling, like you said, there's so much that's out of our control. And so I think that when you're thinking about heart disease or something like that, there's a lot in control, and we don't like that because we don't want to do the things that we can do to 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 keep ourselves from getting,
Right.
that heart attack or stroke. I mean, we don't want to eat healthy, we don't want to exercise, we don't want to do those things that we know we can do. So going back to, let's talk about some other things that women can do that are in their control to help to decrease their risk for breast cancer.
Absolutely. So, most of the things that you can do to help reduce your risk for breast cancer are kind of things that you would do for your overall health. So maintaining a healthy lifestyle, which includes at least 30 minutes of exercise 5 to 6 times a week. And this doesn't have to be like going to the gym, pumping iron, running on the treadmill. This is a movement that's going to get your heart rate up and get you a little sweaty. Some of the exercise programs that I do call it the glazed donut look, where you just have this glaze, and that's really easy to do in Florida. So that helps in a couple of ways. So one, the more muscle mass that you have, that helps decrease your risk for breast cancer. And then the less fat that you have helps decrease your risk for breast cancer. So some of the most common types of breast cancers that we see, like estrogen. And estrogen comes from many places. So it comes from ovaries. Um, and then at a point in time, your ovaries don't make estrogen anymore. And then you have estrogen that comes from your fat cells. And so we always have some estrogen floating around. And if we can decrease some of that in our body, then that can help decrease our risk. The other thing is having lots of fruits and vegetables in your diet is also very important. Now, it doesn't have to be extreme, so it doesn't mean that you have to start juicing. Um, but, you know, mostly having these things in your diet is very good for your overall health and helping decrease your risk of breast cancer. If you want to have pizza and ice cream, that's okay. Have that on occasion, but make sure that you have a well-balanced diet that includes fruits and vegetables. The other thing is you want to avoid excessive alcohol intake. So if you have a glass of wine on occasion, that's fine. But excessive alcohol intake has been associated with an increased risk of breast cancer. And then avoiding smoking. So smoking definitely increases your risk not only for breast cancer, but for many cancers and for other diseases like, heart attack and stroke. So definitely want to try to avoid smoking. And let's see, maintaining a healthy weight. So that's
Right.
another important factor. So you want to try to be within a healthy weight for your height. And so those are just a couple of things that you can do to decrease your risk for breast cancer. And then obviously getting your mammograms every year. So can't stress that enough. You want to make sure you get those every year. And, last year or this last year and a half going on 2 years has just been so crazy. So many things have changed over that time. Um, you know, our jobs, our insurance statuses, the way that we take care of ourselves. And so, if you might have missed your mammogram last year, don't beat yourself up about it. Just go ahead and call and get that scheduled right away. It's never too late to go and get your mammogram done.
And I would say that we definitely, like in our office, I always tell people, people come in all the time and they're like, "Oh, I did that last year." I said, "No, you didn't." So I was like, that was COVID year. We lost a year, and we really
We
did. I
did.
mean, people really forgot about a lot. Not forgot's the wrong word. But basically, especially when it comes to healthcare, a lot of things just kind of just got put by the wayside. If there wasn't a major
Hmm.
problem going on, obviously there was a crisis going on. And so,
Yeah.
like you said, there were other things that were just took a priority. And so that's okay. But now's the time to pick yourself up and get on in. And even though, obviously, as we see, we don't know, tomorrow's not promised as far as um, anything, but definitely as far as what will happen with COVID and whether or not there will be potentially, at least here in Florida, a fifth wave. We don't know that. We don't know if there'll be another variant. But the safety in the facilities is there. So there's no reason,
Absolutely.
because I still get people, believe it or not, that are still afraid to come to the doctors or afraid to go
Mm.
to the hospitals to get their mammograms. First of all, they're freestanding facilities, and so you don't have to be at the hospital if you don't want to be at the hospital. But
Right.
secondly, uh, the hospital has gotten it right, and so when you walk in, it
It's
you
safe.
are not increasing your risk by walking into the hospital to get your mammogram, and so don't be afraid to go in to get any testing that you need to have done, because delaying that testing, when we're speaking specifically, like if you have an abnormal mammogram, do not sit at home and maybe I think we tend to use excuses just because we don't want to know things, but I always tell people that not knowing and digging your head in the sand doesn't make something go away. So if you have cancer, you
Right.
have cancer, and not going in to get that diagnosis is not going to make the breast cancer disappear. What it's going to do is potentially
Mhm.
allow it to get worse and require even more treatment, and make your prognosis worse. So don't dig your head in the sand. Don't blame COVID. Don't blame anything else. Let's take charge of our health,
Right.
and make sure that we get in and we get examined. There's a little bit more of a delay because of, like they do space out the appointments and stuff now, so you may not be able to get
Mhm.
your mammogram. I'm remiss, and I usually like to get it during breast cancer awareness month, so I can remember when I got it and I didn't get in there so on time, so I'll be a November baby. So, but it is what it is. Oh,
Mm.
speaking of which, so let's talk about that. COVID vaccines and mammograms.
Sure. So that's a great point. So, a question that I get a lot of times from patients is, does the vaccine cause cancer? We have no evidence to suggest that the vaccine causes cancer. But what we do know is that the vaccine causes your immune system to become on alert so that when you are exposed to the virus, you can fight it. And in that process, it will cause an enlargement of the lymph nodes. And because you get the shot in your arm, we do see an enlargement in the lymph nodes underneath the arm, which can commonly be seen on mammogram and ultrasound. So sometimes when you go to get your mammogram, you may be asked to come back in 6 weeks, up to 3 months later, to have a repeat mammogram or ultrasound if you had the vaccine um, in that arm. Also, breast cancer can be associated with swollen lymph nodes, so they also have to make sure that there's nothing worrisome in the breast, uh, just to make sure that the swollen lymph nodes are indeed coming from the vaccine and not something else. So it's very common for you to have swollen lymph nodes after the vaccine. That's not causing cancer. And just to be on the very safe side, they have you come back in 1 to 3 months to repeat the imaging to make sure that the lymph nodes still look the same or better.
And what about, so what is the recommendation for, um, if you get the vac, like I'm about to get the third booster. So should I
Right.
wait? I've heard all sorts of things. I've heard anywhere from
Right.
a month to 3 months to get your mammogram after that, just
Yes.
to avoid the callback and the fear and all of that.
Yeah. So I would just, the recommendation has been 6 weeks. So waiting 6 weeks after you get your vaccine to go in, but you do not want to delay going in if you're having a problem.
Oh,
So
of course.
we can definitely troubleshoot what's going on if we see enlarged lymph nodes. But if you're having something going on in your breast, you go right away, no matter when you had your vaccine. But if nothing's going on and this is just your routine screening, then waiting about 6 weeks is sufficient. Now, part of the questions that they ask when you go is when did you have the vaccine and which arm did you have it in? And we're a lot more aware than we were when we first started giving out the vaccine to the general population.
Great, great. So I think that's
Yeah,
important, ladies. So remember that,
yeah,
and we'll definitely put that. I'll make sure that's in the comment section too, because I think that's really important. And like I said, I've gotten all sorts of questions about that, and following up on that. So once again, important to get the vaccine and important to get your mammograms, and they can both be done. So
absolutely.
it's just a matter of timing. But
Absolutely.
I thought about it because, like I said, I was like, oh yeah, I'm about to go get this vaccine, my booster. Let me think about that. So
Yeah,
because my other ones were in December, so it didn't matter. But anywho,
yeah,
so okay, great. So what? Let's talk about mammograms versus thermograms, because that's another thing that we get a lot of questions about. And
sure.
I have what I tell people, so I'll hear what you've got to tell people.
So I'm not an expert on thermograms. So thermograms are not considered as part of standard of care for screening for breast cancer. So the one test that we know works very well and we've used for a very long time is mammograms. It's a good screening tool. It's not very expensive. The amount of radiation that you're exposed to during the exam is very minimal. You probably get more exposure to radiation in the environment over your lifetime than you do in those few seconds or minutes that you get your mammogram. So I think some people do choose to have thermography as an alternative to mammogram because they may have some misconceptions about the exposure to radiation during the exam, but the exposure is very low and not something to worry about. I would say, the benefits of mammography far outweigh any minimal exposure to radiation that you get. And thermograms, it just has not been tested in a wide range for us to know that it's a reliable test for detecting breast cancer.
Right.
Um,
And that's the
so,
key thing.
if you choose that's something that you want to do in addition to getting a mammogram,
That's
that's
right.
fine. But I think we need to stick with the things that we know that work um, and that have been reliable and, go from there.
Now, there was, I don't know, do you guys have a PIM there?
Pardon?
Do you have a PIM, the PET CT for the mammogram, for the breast downtown?
Mm, no, like a CT mammography or a contrast
Yeah,
mammo.
they used to have, well, it came out, when the PET CTs hit, then there was also a PET mammograms basically. So basically it was a PET CT that was just for the breast, and they called it a PIM. And I haven't heard as much about it. So you guys don't have that downtown. There was one in Ocala, but this was a couple of years ago. Like I said, I haven't heard much about it. And it was actually a PET CT specifically for the breast. And so,
It's
the way the
breaking up a little bit on.
oh, can you hear me now? Can you guys hear me? Can you hear me? You look frozen. Did I lose you?
Hmm,
I think you are a little frozen. There you go. Can you hear me
um,
now? You have this look on your face. I think we've lost her temporarily. Let's see. She'll probably pop back in. She's not going to like this picture of herself. She's looks very questionable there. Look, she's questioning the world. Let me see. I think what I'll do is probably knock her out and let her come back in again. I think that's probably the easiest way to do this. Let's see what we can do here real quick. She's sending me, yeah, she's screen is frozen, so she's will come back to us in just a minute, I'm sure. Yep, let's see. Are you back? Okay. Hold on one second, guys. Let me see if I can get Dr. Henry back in here, okay? Yeah, it says you're muted. Let's see. Let's not, hopefully we don't go that route. Okay,
Can
now
you
I
hear
think
me?
you're okay. There you go. You're back.
Okay. All right,
So
perfect.
what I was, I forgot what I was, oh, we were talking about mammograms versus
PET CT.
thermograms. And so what I tell people is that when I get women that come in, I think that couple of things. One is that, as we know, with all the misinformation that's going around with uh, COVID and social media has just, it's got really good things, but it's also got some bad things. And so a lot of stuff, a lot of misinformation just gets perpetuated, and it actually gets shared even more so. And so, for years we've had people that come in and are like, I'm not getting a mammogram because of radiation. And I always tell them, I said, you're looking back at data, there are people out there. Um, and they're talking about, mammograms back in like 1970, and so we've come a long
Hmm.
way from there. And so I think that you have to be careful with your data sources. I mean, people can quote statistics, but where are the statistics coming from? Where's the data coming from? You really don't want to just take that lock, stock, and barrel, because that's really old data that has been negated for years and years and years. But I hear it, and I'm surprised it actually hasn't gotten markedly worse with the advent of the internet, because it's about the same actually as before. Um, like the last couple of years, I hear the same thing, and it's not that common, but when I hear it, it's always surprising to me. And I tell people, I mean, I get on a plane. I'm about to get on a plane next week. And the radiation there is way higher. And then you got these people that
Hmm.
sit there and go, well, I'm not going to get a mammogram, I'm going to get a thermogram. But then they'll go and you got these traveling CT scan people that scan you from your head to your toe. I'm like, why the heck would you do that? Why would you expose yourself
Right.
to that?
Yeah.
You don't even have anything wrong with you, and you're going to allow somebody to scan you from head to toe, and they think that's a good thing, but yet they're afraid to get a mammogram. So it's like, but
Yes.
and I have seen personally in my practice, I've had patients with breast cancer and negative thermograms. So what I tell people is just what you said. You want to do a thermogram, knock yourself out, but get a mammogram as well, because we do know,
Yeah.
and it's all three things. I always say, early detection, early treatment, early cure, God willing, and that you get in, you get your breast examined by a medical person every year. You examine. I still believe in monthly exams. I think that
Yeah.
that's another thing that comes out. Oh well, the American whoever. I'm not going to quote a specific place, but breast self exams aren't important or don't yield anything or don't do it. And I think that my thought, you can tell me what you think. I think the reason why that is sometimes not recommended is because they are thinking that people are finding stuff that's natural and normal and then jumping the gun, and it's leading to way more use of mammograms and excess cost of things. But I think that, so it's not good to just examine your breast out of the blue if you're not used to it. But if you examine your breast every month, you will know what's normal. And therefore, what you're
Right.
looking for is what's not been there, the hard lump or bump that is getting bigger, not going away, doesn't hurt, because breast cancer rarely hurts. There are breast cancers that hurt, but the majority of them don't. And so I think that,
Right.
but if you don't know and you examine, yeah, you're going to flip out and you're going to be, because there may be something there that's always been there. But so that's my
Right.
recommendation on, how what should be done. We already talked about the mammograms, but as far as self breast exams, that I still do recommend those. And then I do recommend that you get in, either to your gynecologist or your primary care doctor, and let somebody lay hands on you every year and examine. And ideally, not at the same time as you get your mammogram, so you kind of spacing things out a little bit. But
Yeah.
what's your thought?
That's it. That's definitely an ideal world, that
Yeah.
you see your doctor at one point and then your mammogram is at a different point in time because that helps, you know, get you checked twice, and not all at the same time. Mammograms are very good. They detect about up to 90% of all cancers, but a couple things can happen. Sometimes you can't detect all cancers on mammogram, so that's why self-awareness is so important. Two is that some cancers are sneaky. They grow really fast. So
Yes.
even if you had a negative mammogram and you're not due until next year, sometimes something can grow in that time. So definitely self-awareness is key. Now, I think there's a lot of validity to what you were saying regarding self-breast exam. Some women may do it for the first or second or even the third time, and they're like, oh my God, like I feel lumps and bumps everywhere. I hear that all the time. Like I have lumpy, bumpy breasts, so I just don't do my exam. That's okay. Like having lumpy, bumpy breasts is completely normal. You are going to be the best expert on your breasts compared to a physician who only sees you once a year. And so, with that being the case, like if you do it every month, then you will be able to detect a change much sooner than your doctor will. And you can bring that to their attention. And you shouldn't be, afraid or feel embarrassed if you feel something and you think it's abnormal. Just talk to your doctor about it. And, they can provide you reassurance or order the imaging that you need to get it detected. I mean, it's so easy to get an ultrasound or a mammogram too if needed, if you have an abnormality in the breast. So definitely, I'm a proponent for self breast exams. There are many women who don't meet criteria to have mammograms yet, who felt a lump in their breast, and it unfortunately turned out to be breast cancer. And so if they never felt, then who knows? So
Right.
definitely, it is important to do.
And also, like we said, with COVID, I mean, things come up. And a lot of people
Hmm.
think they just got their mammogram and they didn't,
Right.
And so it's just, you got to do everything. If you're doing everything, then, if this doesn't catch it, that'll catch it. And that's the goal. I mean, you can do, as you said, I always say there are bad things that happen to good people. So you can only control but so
Yeah.
much. So the key thing is that we can't control, whether you actually get breast cancer, but you want to catch it as soon as possible because that does actually affect significantly your survival chances. And that's the main goal. You don't want to get it at all, but if you get it, you want to be a survivor. And so doing the
Right.
best you can to kind of catch things early on is really important. And so let's talk about
Yeah.
that. Let's talk about um, family, you know, uh, having breast cancer
Sure.
in the family versus, primary breast cancer risk and stuff, because there are a lot of people that, think, okay, well, if I don't have anybody in my family that has breast cancer, I mean, I'm okay. I'm not going to worry about that.
Absolutely. So I hear that a lot. Like I'm very surprised that I developed breast cancer. Like no one in my family has breast cancer, or, breast cancer doesn't run in my family, so I won't get it. The truth of the matter is that most breast cancer does not run in families. So about 70 to 80% of all women who are diagnosed with breast cancer will not have a family history of breast cancer. So only a very small proportion of women who develop breast cancer have a pattern of breast cancer in their families. So it's really important that everybody gets checked out because it can happen to anybody. Now, for women that do have a pattern of breast cancer in their family, this is very important to know. So it's so important, like especially when we have these family gatherings or whenever you feel the time is appropriate to talk to your family members and figure out if anyone's had cancer in the family. Was it breast cancer? Was it ovarian cancer? Because those two types of cancers can be linked. And how old were they when they had the breast cancer or ovarian cancer? For these people who have a lot of these cancers in their family and they see it in multiple generations, so their great grandparents, their grandparents, their, aunts, uncles, or their mothers, or their sisters, or their brothers, whoever they may be, then this is something that may be suggestive of cancer running into the family. Those people should seek the attention of their physician and be considered for genetic testing. Because if you were born with something that's passed along in the family, then there are things that we can do to try to prevent breast cancer before it even happens, because we know that you're at an elevated risk. So we can do enhanced surveillance, where in addition to a mammogram, once a year, starting 10 years before your youngest diagnosed family member. We can also do a breast MRI once a year. And we try to space those out 6 months apart so that we can check you twice a year and watch you very closely. And then, some patients choose to have their breasts removed before they develop breast cancer because their risk is so high. So we do that very commonly for patients that have the BRCA1 and 2 mutation, also commonly known as BRCA1 and 2. And those patients sometimes get surgery before they develop cancer. So those are kind of some things to keep in mind related to family history and breast cancer.
Yeah, and also we sometimes remove uterus, the ovaries, so we don't remove the ovaries without the uterus. You don't want that. But we can do the prophylactic removal of uterus and ovaries in some people that have the very high risk with the BRCA. It's more even BRCA2, but BRCA1 and BRCA2. And so
Yeah.
there are different routes that people choose that are extremely high risk. So these are people that have been tested and have the strong family history as well, where usually that's recommended. I'm getting ready to take somebody now. And so there's options out there. So I think that once again, if you have the strong family history and or you test positive for one of the genes that is associated with it,
Mhm.
it does not mean that you're definitely going to get breast cancer. It means that you're at a much higher risk and you want to do things that are in your control to try to decrease that risk. But it doesn't mean that that's an automatic, I'm definitely getting breast cancer, I'm definitely dying breast cancer. So, I always tell women we are uh, women, we're good at being proactive, like give us the information and we can take it and roll. It's that the unknowing and is the really scary part, that in the and so because sometimes people say, well, I don't want to do the BRCA testing because I don't want to know. And it's like, well, right now you think you're a walking time bomb, so you might as well get the information, because most of the time you're actually negative. And just because you're negative for BRCA1, BRCA2 doesn't mean you can't get breast cancer, doesn't mean it doesn't run in the family, but there may be something else running through that family. But the more data that's obtained, the better. I think that it's more reassuring, and it kind of helps with anxiety to have done the test, because if you're positive, okay, what do I do, to make this better? If you're negative, it's like, okay, I can relax, and not that I can't get breast cancer, but I don't have to feel like I've got this gauntlet over my head the whole time. uh,
Mhm.
and also some people are afraid to do the testing because they think that it's going to make their insurance rates go up, or that they're not going to be able to get life insurance or health insurance or something like that. First of all, that's illegal, so they
Mhm.
cannot exclude you. And already, when you're applying for your life insurance, if you've got family history sitting there, they're already flagging you, and they're already putting up your risk and raising your rate right off of that. So if you do the BRCA testing and it's negative, that's actually ammunition for you to go back and go, even though I've got all this breast cancer running around in my family, I'm BRCA negative, so I don't want you holding that against me. So it's actually a positive. The other positive of doing the testing is you don't have to fight your insurance company to get the MRIs, to do the extra testing, because you have something there that says, hey, I'm high risk. Otherwise, with just the
Right.
family history, sometimes, I don't know, maybe because it comes from you, you're able to get away with it more, but we fight. Like, say, for a breast MRI, we have to fight, and promise our firstborn to get a client sometimes approved for MRI. So the testing can sometimes make that a much smoother process than when you don't have the testing done. And you guys offer that
Absolutely.
downtown, right? You guys have a genetic tester at right there.
Yeah. Yeah. So
So
we
we
have
do send in.
a high risk and a cancer genetics department, and so they, will calculate a woman's risk for breast cancer. So anyone who has a lifetime risk greater than 20% of breast cancer is considered high risk. So that's with or without a mutation like BRCA1 or 2. And they would qualify to have an MRI once a year as well. And then they also will test um, patients who meet criteria for genetic testing to see if they were born with something that increases their risk for all types of cancers, not only breast cancer. Yeah. I think
Great,
one of the
great.
things where we fall short in some families is that we just don't talk about health problems. So, I mean, this is just kind of like free information about things to be looking out in your own health. And it's, empowerment for our families if we can talk about different, illnesses that people may have had so that we can take better care of ourselves and our entire family.
And that's definitely true. Oh, did we lose you? You're talking, but I don't. Are you still okay? I think there's a little bit of a delay. So,
Yeah.
so, I think that especially like say in African American families, I think it's getting a little bit better, but definitely that was something you just didn't talk about health. It was like it was considered none of your business, and so people are very secretive about cancers, any kind of health condition. And so it was very hard to tease things out. I think we're coming a little bit better with that. I don't know if it's different, like say with people that are coming from other countries and stuff, or if it's still more taboo. But I think we're hopefully coming a little bit better with people sharing information. But it is important to discuss it because you got to know. You got to know what you what you need to know.
Yeah. Yeah,
So, what else?
absolutely.
Do you have anything else? I've got some other things that are a little bit more technical. But do you have anything else that I'm missing that you really wanted to get across? And if not, I'll ask you a couple of more questions and we'll get off. So I try to keep it to an
Yeah,
hour.
no, I'm
My
ready to hear what questions you have.
So, of course, I'm a gynecologist, and so I deal with a lot of my patients that have already had breast cancer. And so, one of the things I think that um, first of all, just real quickly, you could tell people the difference because I think that people automatically assume that if they have breast cancer, that they have a hormone sensitive breast cancer. So just describing, without getting too technical, the difference between the different types of breast cancer that people can get that is not just breast cancer.
Yeah. So, um, there's different parts to the breast, just keeping it simple, where breast cancer can develop. The most common part of the breast is in the duct. The second most common is in the lobule. Those are some technical terms there. And then the next step is when somebody develops cancer, we do special tests on the tumor that give us more information about how the tumor behaves and how we can treat it. One of those tests is estrogen. Estrogen is a hormone that everyone has in their body. So women have a lot of it, men have some of it too. And the estrogen levels in our body are highest before we go through the change or menopause. And then after that, our estrogen levels decline, but they don't go to zero. So we still have other sources of estrogen in our body at that time. So the most common types of breast cancer that we see in all women like estrogen. And so when someone gets a breast cancer diagnosis and that cancer likes estrogen, one of the tools that we have available for help reducing the risk of the cancer coming back in the future is by blocking estrogen in the body. So we will usually give them a pill anywhere from 5 to 10 years that blocks estrogen in the body and helps reduce the chances of them having another cancer that likes estrogen in the future.
Right. And I think that that's and what I always tell people though, your breast likes estrogen too. So the good thing about having a hormone sensitive cancer is that the cancer actually knows where it's at because we have there's uh, well differentiated cancers, moderate and poorly differentiated cancers, and so you don't want a cancer that's not trying to mimic the organ it's in. That's actually kind of scary, and those are the most aggressive kind. So having a cancer that actually is sensitive to
Mhm.
estrogen or progesterone is actually a good thing. And I know with the hair too, there was, at first it was like bad, now it's good. Well, not good, it's not a bad thing anymore because they just like we have drugs
Yeah.
to trick the body into thinking it's getting estrogen and it's not, that can be, help to defend against the cancer. We have now HER2 drugs that we can use to try to trick the body if it likes hair too, right? The breast or the cancer, excuse me. And so I think that that's not as much of a right. That's
Right.
okay. So I think it's just that we
Yeah,
it's taking
definitely.
stuff to get to try to come up with the best treatments that you possibly can. and that like you said, cancer, I mean, estrogen hormones, everybody has them. And if you think about it, the breast cancer risk, as we said, goes up the older you get, even though the estrogen levels are actually lower the older you get. And so it's not necessarily because, of course, we get that, well, you know like as far as hormones and stuff like that. And so I think that it's I tell people, obviously I do a lot with bioidentical hormones, but we follow levels. And there's certain medications that I will not prescribe for that I didn't before. And it's this there are certainly too much of a good thing can be a bad thing. And because we do produce estrogen in our bodies, and that's, I think, one of the things that when estrogen came out on the market, it was being used in much higher dosages, and they were like touting it as this miracle drug. And then it continued to go that way. And the biggest drug out there was Premarin, which was made of 33 different types of estrogen. We don't make 33 types of estrogen, and we only make three. And so we were giving, not we, but there were people, taking in, and there's still some people, not as many are on Premarin as they used to be, but, taking in all these different estrogens. And so I always tell people, whenever you're putting in foreign things into your body, it has to kind of figure out what to do with these things. And sometimes it doesn't figure it out the best way. But that goes for, you can get me down a whole tangent because, I'm very much into natural foods and all this
Yeah.
processed garbage we eat. And I think that that's a big proponent for all these cancers and all this disease that we have because we put so much garbage, processed garbage in our mouths every single day. And I think that that's actually probably one of our biggest culprits with getting a lot of
Yeah.
this stuff because it's stuff our body doesn't know what to do with. Our body doesn't make this stuff, and it's got to figure out what to do with
Yeah.
all this stuff that is constantly being given to it that it um, doesn't naturally recognize as its own. So, and
Yeah.
so that was my big one is that, the other thing is just the tamoxifen versus Arimidex. And because, a lot of the breast cancer, it seems like a lot of the surgeons are kind of very much like, all right, premenopausal, you must be on tamoxifen. You can't be on Arimidex. But then afterwards, it's okay. So I know what I've heard, but tell me what your thought process is on tamoxifen versus Arimidex and the age, etc., if you can.
Absolutely. So one is I want to say that estrogen is a miracle drug because I do believe that it does make women feel better. It really can provide a lot of quality of life. And so, the jury is still kind of out on how much effect does hormone replacement have on the development of breast cancer. And we could have a whole 1 hour discussion about that. But I do think that, it should be considered on a case by case basis and that if you do need to be on these medications that you're on the lowest possible dose like you talked about, lower doses are better, that you're being monitored by a physician and that you only take it for as long as you need it. So that's my opinion on the hormones. And then as far as tamoxifen versus arimidex or different medications that are in those groups like arimidex.
And these, I'm
So
sorry, guys, let's tell them just briefly because I guess I jumped the subject. So, what these are,
sure.
what kind of medications these are, so they know these are medicines used after you've
Right,
had breast cancer um,
right.
to help to decrease
So
recurrence.
right. So these medications are medications that block estrogen in the body, which help decrease the risk of developing a breast cancer that likes estrogen. These are mostly given to women after a breast cancer diagnosis, and it's somewhat considered as a maintenance medication. So it's not chemotherapy, but it's something that you take every day for 5 to 10 years that helps decrease your chances of the cancer coming back. Now, we do sometimes use tamoxifen in women who have not developed breast cancer but are at a high risk. And we can reduce the risk for breast cancer up to about 75% in certain women by giving them that medication without a breast cancer diagnosis. But back to your question, um, the tamoxifen or medications like that are given to women before menopause because, like I explained earlier, how we have the estrogen in our body is different compared to before menopause and then after menopause. So the tamoxifen works to control the estrogen that comes from ovaries, and then Arimidex and medications like that control the estrogen that comes from other parts of your body after menopause because you're not making it in the ovaries. Now, what the data shows us is that women who have estrogen positive breast cancer should be on this medication. And some of the later trials have shown that women who are premenopausal that have ovarian suppression do better, ovarian suppression plus the postmenopausal um, estrogen blocking medication do better than just being on tamoxifen. So you may see that a woman who hasn't had menopause yet that develops breast cancer that likes estrogen will be recommended to have a shot that turns the ovaries off and then also given the medication that blocks estrogen for postmenopausal women. So there's been shown to be a lot of benefit to basically making premenopausal women postmenopausal if they've been diagnosed with an estrogen positive breast cancer.
So you're talking about like giving them Lupron or something?
So they use goserelin, if I'm remembering correctly, and they give them that, and I think it's every couple of months. Now this is I do the surgery part, not so much the medication.
I gotta look this
Um,
one up.
so yeah, so either they can have a oophorectomy or they get the injection to turn the ovaries off, and then they give them the
Tamoxifen on
postmenopausal
top of that,
medication.
or
Not
Arimidex on top of
tamoxifen, so they Arimidex, right.
that? Okay.
So some of the Taylor-X study showed that basically women who were postmenopausal after their breast cancer treatment did better than those that were still premenopausal.
Huh.
And there's a lot of things without getting too technical and boring everybody, but basically we saw that after chemotherapy, women became postmenopausal and those women tend to do better than those that did not. And so, you know, we are still teasing through the data to decide whether it's actually the chemotherapy that's improving their outcomes or is it the ovarian suppression that comes from the chemotherapy. And
Right.
I think
Right.
the Taylor X showed that ovarian suppression plus an aromatase inhibitor, so that's the group of medications that block estrogen after menopause. Those patients did better.
Right. Right. And I just,
Yeah.
you saw my face squinching up because I'm just like, oh my God, how are they going to feel? So,
Yes.
so,
So
so that sounds
yeah.
like a cocktail made from not a
Yeah.
good place. But, so I think it's,
To answer that question, though, we have this conversation a lot because it is like very tough to. So the ladies that do the worst or have the hardest time, I should say, with blocking estrogen are premenopausal women. So they have lots of estrogen and then we take it away very quickly and it's like a shock to the system. And so when we counsel ladies about taking the estrogen away, there's two options. They can have their ovaries removed or have the shot and take the pill. And some women feel like, oh, I just want to have my ovaries removed, like get them out and be done. But there's no going back from that. So some of the
right,
medical oncologists will recommend let's try the shot for a little bit with the medication that blocks estrogen for postmenopausal women. And if they do okay, they stick with that. And if they really struggle, then they'll just put them on the tamoxifen. So
right,
it gives
right,
them some options there. But usually, my postmenopausal women do really well with the hormone blocking medicine
right.
because they're used to having lower levels of estrogen.
Right. Arimidex is definitely well tolerated compared to tamoxifen. We get,
Yeah.
women, and obviously it just depends on the person, like you said. I mean, and there's so much with any medication. It's always your body's response to it, and everybody's body's response can be different. And also your mental thought process as far as, the cancer, the treatment, and longevity of life and symptom control, et cetera, et cetera. So I think it's definitely a case by case, but I would say that as far as just generalized side effect profiles, yes, you do see more complaints with tamoxifen than you do with Arimidex. Definitely better tolerated one. And so, like I said, we usually will end up where if the recommendation is, if we're not seeing, and I see sometimes where the tamoxifen is not suppressing as well as it should be, and so sometimes taking the
Mhm.
ovaries out if they're high risk is still the better option, and then putting them on the Arimidex. And there's lots of natural things that we do for afterwards. So I think that it's also important that women know that whether they're dealing with breast cancer actively or if they're post breast cancer, that you don't have to sit there and be miserable. That is so not necessary. So I always tell my clients, I'll take you from soup to nuts, and we do a lot with natural therapies, with supplements. But just because it's not estrogen doesn't mean it's safe. So just running out and buying stuff from CVS or the health, and I'm not bashing CVS, but like from the drugstore or from the health food store, just because you can pick it up from the store without a prescription doesn't mean that it's safe for you. And that's a big, scary thing that I see a lot. And so you do have to be careful with herbs. I mean, if you're actually, a lot of stuff over the counter is garbage, but if you're actually getting something and it's actually working, things that work, that everything that has a positive potentially has a negative side effect. So if you're really getting into herbs, you really need to be educating yourself, or you need to be under the care of someone that knows the good, the bad, and the ugly regarding that particular herb or supplement that you're
Mhm.
taking. But there's a lot of things that we have out there that are non-hormonal for people that um, are post breast cancer. We do a lot with testosterone therapy if they are far enough out from their cancer, and we do, like I said, just all sorts of things. We have for vaginal dryness, we have like we use the O shot, we do radio frequency. So there are things that are non-menopausal that we can use to address many non-hormonal that we can use to address many symptoms. So don't be out there if you're a breast cancer survivor and you are not coping well with being, menopausal, um, and toughing it out, because there's things that can be done. So
Absolutely.
we are over our hour by 1 minute. Well,
Oh,
actually, we're
wow.
not, because I was talking to myself for the beginning of the whole thing. So I want to thank Dr. Henry. I really, really appreciate you
Yeah,
coming and speaking with us.
absolutely.
And maybe next year we can get you in earlier for Breast Cancer Awareness
Absolutely.
Month. But at least we caught you before the end of it. And
Yeah.
if you guys have any other questions, that we had a quiet group today, but if you guys have any questions specifically, feel free to put them in the comment section even afterwards. And either myself or I will get them to Dr. Henry and make sure that she gets those
Okay.
answers back to you. She is located here in Orlando. She's an excellent breast surgeon. We send our clients down there all the
Thank you.
time, and we get nothing but positives back
Oh, thank you
from
so much.
their. It's a very well-oiled machine down there, as far as getting patients their diagnosis, and their treatments, and getting them where they need to be with their cancers. And they explain things in very clear terms. I don't get people coming back going, I don't feel comfortable or what have you. So I think I definitely, we do not want you to have an abnormal mammogram or have a diagnosis of breast cancer.
Yeah.
But if you do and you are looking for someone to see, then the Orlando Health Cancer Institute is definitely an excellent place to be. So thank you so
Thank you
much.
so much.
Have a wonderful weekend. And as you guys know, I will see you next Friday at 4 p.m. And hopefully, I will not be talking to myself again. And I will
Mhm.
uh, um, um, have you uh, well, we'll be going into November, but I did not really, because I was absent for a couple of weeks, we didn't talk about the other important part of October, which is actually domestic violence. So next week we are actually going to delve a little bit into domestic violence, because that is something that's very, very important for um, everyone, but definitely for our females in particular. Not to say that there's not domestic violence in men as well, there is, but we will talk about it for all people. And like I said, because that's something that is October, and we didn't delve in. So stay tuned next Friday at 4 p.m. And as always, have a wonderful weekend. Stay healthy, stay safe,
Bye,
and
everybody.
I'll see you soon.